Hi everyone, welcome to our module on restrictive lung disease. In the module on pulmonary function testing, I talked about the pathophysiology of restrictive lung disease in detail, but just by way of review, let me highlight some of the key points. So the primary problem in patients with restrictive lung disease is that they can't get air into their lungs. This means they're going to push less air out with each breath, but it's not that there's a problem with the mechanics of getting air out, it's just that they've brought less in, so necessarily less goes out. This means they'll have a reduced forced vital capacity, again, because less air was brought in, so less goes out, and they'll have a reduced forced expiratory volume in 1 second for the same reason. Importantly, though, the ratio of FVV1 to FVC will be normal or greater than 80%. 80% is a normal ratio. In patients with restrictive disease, it's normal or increased, and that's the hallmark. In obstructive disease, this ratio goes down. So there are basically two causes of restrictive lung disease. The first cause is poor breathing mechanics. We'll talk about that in a minute. And the second cause is interstitial lung diseases. So patients with restrictive lung disease from poor breathing mechanics do not have a primary pulmonary issue. Their problem is that they're underventilating the lungs due to some issue with the total apparatus that draws air into the lungs. Their alveoli are healthy and working, and this means if you measure an AA gradient, it will be normal. And if they tell you about a patient with restrictive lung disease and a normal AA gradient, they're describing someone who has poor breathing mechanics. So what interrupts your breathing mechanics? Well, you can have a neuromuscular problem like ALS or polio or myasthenia gravis. Patients with these diseases can't activate the muscles in their lungs properly to draw in a deep breath, and they develop restrictive physiology even though their lungs are healthy. Another reason for poor breathing mechanics is structural disease. So if you have scoliosis, which means a curve in your spine like this, it's hard to inflate the lungs fully because of that abnormal thorax, and this will give you a restrictive lung problem. Patients with morbid obesity also have restrictive lung disease. They have so much extra tissue on their body that they can't inhale deeply and draw in enough air. The second reason patients get restrictive lung disease is because they have interstitial lung disease. And these diseases get their name because there's a pathologic process that starts in the interstitium. Now, the name's a little misleading because the pathologic process also involves the alveoli, and there's often destruction of the alveoli as well, but the interstitium is always a component. So these patients have sticky tissue, usually fibrous tissue and inflammatory tissue in their interstitium, and this prevents their lungs from inflating normally, and it restricts the lungs so that they can't inflate fully. They have characteristic findings on imaging. So over here on the right is a patient with interstitial lung disease, and you can see these streaky infiltrates with dark stuff in between them. It's often described as honeycombing. Over here on the left is a CAT scan of someone with interstitial lung disease. They also have white stuff throughout their lung fields. These fields should all be black, and they also have little holes between them, the honeycombing pattern. It's described as a bilateral diffuse pattern with small irregular opacities that are often called reticulonodular, and then, as I said before, that honeycomb lung appearance. To understand interstitial lung disease, you have to understand a diagnostic test called the DLCO, and DLCO stands for the diffusing capacity in the lung of carbon monoxide, and the DLCO test separates cases of restrictive disease. If you have restrictive physiology with a normal DLCO, this means your alveoli are working and you have an extrapulmonary cause like I talked about before, for example, obesity. If you have restrictive physiology with a low DLCO, this means you have interstitial lung disease. The hallmark of interstitial lung disease is a low DLCO. So let's talk in a little more detail about what the DLCO test is. So the DLCO test measures the diffusing capacity of carbon monoxide. It measures the ability of lungs to transfer gas to red blood cells. What happens in this test is the patient inhales a small amount that's not dangerous of carbon monoxide, and recall from our physiology modules that carbon monoxide uptake is diffusion limited. The amount that gets taken up by the body is proportional to the diffusion function of the lungs. A machine measures the amount of carbon monoxide that gets exhaled. A normal result is about 75 to 140% of predicted, and patients who have severe interstitial lung disease have a very low DLCO, less than 40% of predicted. Essentially, the interstitial lung disease interferes with the ability of the body to uptake carbon monoxide, and therefore they will have a very low DLCO. So what are some diseases associated with a low DLCO? Well, interstitial lung disease can definitely do it. If you have emphysema, you get destruction of your alveoli, and that will cause you to have a low DLCO. If there's something wrong with the vasculature that impairs the ability of blood to pick up carbon monoxide, like pulmonary hypertension or pulmonary embolism, this will lower the DLCO. A couple of other unusual things: if someone's had a lung resection for a tumor, they may have a low DLCO. Their alveoli are healthy, but they just have less alveoli around because the surgeon removed some of them. And then finally, patients with anemia have low DLCO because they don't have enough red blood cells to pick up the carbon monoxide. This will be normal if you adjust for the hemoglobin level. So note that not all of these things give a restrictive lung pattern. So you can see a DLCO that is low in diseases that aren't restrictive. The primary restrictive disease that has a low DLCO is interstitial lung disease. So let's talk in a little bit more detail about the interstitial lung diseases. These are sometimes called diffuse parenchymal lung diseases to give you a better picture of the tissues that are involved. It's a large group of disorders, but they have similar clinical, radiologic, physiologic, and pathologic manifestations. They all give you those interstitial patterns on imaging, and they all have restrictive defects on pulmonary function testing. The classic example of interstitial lung disease is idiopathic pulmonary fibrosis, which we'll talk about in a minute. This is where fibrous tissue is diffusely laid down in the lungs, and that makes it hard for the lungs to inflate and gives the patient a restrictive defect. There are a number of systemic diseases which have interstitial lung features. So if you have scleroderma or rheumatoid arthritis, these autoimmune diseases can involve the lung and give you an interstitial lung pattern. Patients who have good pastures and Wegener's can also have the antibodies affect the lung, and they can develop an interstitial pattern. And then finally, patients with sarcoidosis sometimes get diffuse granulomas inside the lungs, and this gives them an interstitial lung disease pattern. There are occupational exposures called pneumoconioses that can cause interstitial lung disease. We'll talk about those in this module. There are also some drugs like amiodarone and methotrexate which cause interstitial lung disease. And then finally, there's a condition called hypersensitivity pneumonitis. And we'll go through all these things in the rest of this module now. So idiopathic pulmonary fibrosis is a collection of different disorders that all have a little bit different pathophysiology. The most common type is called idiopathic interstitial pneumonia, and this is a condition that gives slow onset dyspnea, usually to older adults over the age of 40. I've seen a number of patients with this in their 70s and 80s, and they present with slow onset dyspnea, and then chest x-ray or CAT scan shows that honeycombing pattern, and they have pulmonary fibrosis. And this is very difficult to treat. They often need to go on oxygen, and there aren't specific therapies to reverse the course of the disease. Pneumoconioses are called occupational lung diseases because these are lung diseases people get as part of their job. There are three that you should know about. We'll talk about them in this module now. The first one is coal miner's lung, the second one is silicosis, and then finally asbestosis. Coal miner's lung happens when coal miners inhale coal dust particles, and on chest x-ray or chest CT, you see small rounded nodular opacities, and one thing that's worth knowing about this is that it has a preference for the upper lobes of the lungs. Silicosis happens when you inhale silica, and these are tiny rock particles, usually from quartz, but sometimes from granite or sandstone. And if you've ever been at the beach and the wind whipped up some sand, you inhaled silica because there's silica in sand. Now those particles at the beach are usually too big to get down into your lungs, but some workers are exposed to very small particles that can get into their lungs and cause silicosis. It's the most widespread pneumoconiosis in the United States, and workers that are at risk are foundry workers. So foundries are places that make metal, and you might think if they make metal, why is there risk of exposure to silica? But that's because many of the metal castings that are used to shape the hot metal are made of silica and quartz, and you can kick up dust when you clean them. Sandblasters are exposed to silicosis, so there are a lot of occupations where you spray a high pressure material made up of sand or small silica particles at something metal to shape it or smooth it. This is called abrasive blasting, and this can kick up a lot of silica dust. And then finally, workers in mines are exposed to a lot of silica dust. When people were laying down railroads across the United States in the 1800s and 1900s, a lot of workers got sick from silicosis from working inside those mines. Some high-yield things to know about silicosis, especially for step 1, are that macrophages are the cells that react to the silica. This leads to inflammation, it draws in fibroblasts, and collagen gets laid down, and this is what leads to the restrictive lung disease. There's a very high prevalence of tuberculosis among occupational workers with silicosis, and it's believed that this is because there's impaired macrophage killing of the tuberculosis bug. There's also a very high prevalence of bronchogenic carcinoma among silicosis workers. Just like coal miners' lungs, silicosis tends to affect the upper lobes, and there's a classic radiologic finding for silicosis you should know about called eggshell calcification of lymph nodes. So if you look at this x-ray over here on the right, I'm drawing with my pen around a lymph node that's well circumscribed with white stuff inside it. This is called eggshell calcification. The reason for this is not known, but it's commonly seen in patients with silicosis. Final occupational lung disease we'll talk about is asbestosis, and this happens when workers inhale asbestos fibers. So asbestos is used for insulation. It's very strong, it's fire resistant, so you usually won't see it. It's found inside the walls of structures. So you'll find it inside the walls of ships, you'll find it under roofs, and you'll find it surrounding pipes in plumbing. Workers who inhale asbestos fibers and get asbestosis classically have problems in their lower lobes. So this is different than the other two occupational lung disorders which affect the upper lobes. And patients who inhale asbestos fibers essentially get three clinical problems. The first is they get interstitial lung disease, which is what asbestosis is. They also develop pleural plaques, and then finally they develop lung cancer. So the classic finding on chest x-ray of asbestosis are called pleural plaques. This is an example of one here at the tip of this white arrow. They're very hard to identify if you're not a radiologist. They're going to be difficult to pick out. But what you can notice on this x-ray is that there's a lot of white stuff here at the edges. There's some of it over here. And that's where the pleura are. And so when you see abnormalities at the edges of the lungs where the pleura are in an occupational worker, you should think of asbestosis. On lung biopsy, the classic finding of asbestosis is called an asbestos body. It's also called a ferruginous body. And these long string of pearls types things that you see right here, these are asbestos fibers surrounded by a coating of iron and protein after they've been phagocytosed by macrophages. There are two cancers that patients with asbestosis are at increased risk for. The first one is bronchogenic carcinoma. Now, a lot of patients who are exposed to asbestos also smoke, so it's tough to tease out what is the causative factor. But you should know that the greatest risk for patients with asbestosis is bronchogenic carcinoma. A lot of students want to say mesothelioma because they know that's associated with asbestos, but mesothelioma is much more rare compared to bronchogenic carcinoma. Now, mesothelioma is a special cancer, and asbestos is the only known risk factor for this malignancy. This happens decades after exposure, so it's going to be someone who worked in shipbuilding, for example, many decades ago. On x-ray, they have thickening of their pleura and often a pleural effusion. If you see a pleural effusion in a patient who was an asbestos worker many decades ago, a mesothelioma is one of the first things you should think about. The symptoms come on slowly. Usually they have dyspnea, cough, and chest pain over time. The chest pain is because the pleura is involved, and that gets stretched when the lungs inhale. And this has a very poor prognosis. It's very difficult to treat. There are a couple of drugs that are associated with interstitial lung disease you should know about. So bleomycin and busulfan are often used as anti-cancer agents. Amiodarone is an antiarrhythmic. It's often used to suppress atrial fibrillation or ventricular tachycardia. And we use the lowest dose possible of amiodarone in patients with AFib because the risk of pulmonary fibrosis is higher the more dose that they're exposed to over time. And then finally, methotrexate, which is an anti-inflammatory, has also been associated with interstitial lung disease. And then the final cause of interstitial lung disease I'll talk about is hypersensitivity pneumonitis. So this is basically an allergic reaction involving the lungs. So some type of environmental antigen triggers an immune reaction. This can be caused by agricultural dusts. Some microorganisms, like some fungi, bacteria, or protozoas can cause this, and some chemicals can cause this. It's a mixed type 3-4 hypersensitivity reaction. So recall that type 3 is an immune complex reaction and type 4 is cell-mediated, and both of those are involved. The classic case, and the one you should definitely know for your boards, is farmer's lungs. This is where moldy hay or grain exposure in a farmer elicits this condition. It's also common in bird and poultry handlers, so the waste from the birds becomes dried and finely dispersed dust, and this triggers the hypersensitivity reaction. So the classic case is going to be a farmer or a bird handler who develops cough, dyspnea, and chest tightness, and usually they have diffuse crackles on lung exam. The diagnosis is challenging. There are many different tests that are sometimes used. Sometimes these patients have a bronchoscopy where a camera is inserted into the lungs, and then they will wash the lungs and analyze the fluid. That's called a bronchoalveolar lavage, and they can analyze the cell types in that lavage to look for evidence of this condition. Sometimes they have them inhale something to see if that elicits the reaction, and then rarely lung biopsy can be needed. And the treatment mainly is to avoid exposure if possible, and sometimes if the symptoms are very severe, steroids are given to knock down the inflammation. Remember, this is like an allergic reaction, so steroids are helpful. And that concludes our module on restrictive lung disease.